When there's an NGS test that's ordered by a clinician or a pathologist, in our institution, we foster pathology-driven test utilization that is actually shown to lead to improved outcomes and better utilization of testing, as well as improved time to treatment. And so when a test is ordered, the appropriate slides are prepared. Actually, the sample is accessioned, and the slides are prepared by the anatomic pathology division and then handed off to the molecular pathology team that then proceeds to actually review the case, the clinical history. Is the test appropriate? Are we performing the right test for the right patient at the right time? If not, then we may make a recommendation for a test revision, and then that will go back to both the molecular pathology accessioning team and sometimes the AP managers as well. We will re-review the H&E slide and make sure that you have adequate quantity as well as quality of tumor. There's a certain tumor percentage requirement that you need to adhere to in order to be able to go downstream in your next generation sequencing protocols. Is there adequate quality of tumor? The picture that I'm showing here on the lower right-hand side, this image over here shows a lot of tumor necrosis. And so that can be an inhibitor to the PCR. So these are things that the pathologist will take into consideration, and then they will outline an area of the tumor that is best suitable for next generation sequencing. And then we have technologists that will micro dissect that tissue for next steps. The other question that comes up is, can the test be performed? And sometimes you have very limited tissue and you may need to Q&S the case, and that means rendering a report that says quantity insufficient, or you may need to cut more sections and get more tissue into your system, or you may need to fall back on single analyte tests because you don't have enough for comprehensive molecular profiling, but you do have enough tissue for single gene tests. So as you can see, it's a very complex process. There's a lot of effort by the physician, by anatomic pathology division, as well as the molecular pathology division, to make sure that you have the right test, but also the right amount of tissue and DNA for downstream steps. So our analytic efforts include, as I mentioned, the tissue microdissection that is performed by technologists within the lab, DNA, RNA extraction, and then sequencing. After sequencing is done, we have a bioinformatics team that processes the data and all of the variants. That's a very significant analytic process. And then an initial report is rendered that's reviewed by a technical director and then by a physician, where the report needs to be integrative and highlights any diagnostic, prognostic, as well as therapeutic significance. Other things to keep in mind about the report that gets generated is the transmissibility into the electronic medical record. And so you have to design your report so that it is lucid, it's easy to follow. All of the information that comes out of your testing is right there and doesn't require a lot of time investment to understand what's going on for the patient. So that is another really important post-analytic step that we all need to be thinking about. You have to organize all of the information. Again, we're busy physicians, pathologists, and oncologists, and within 2 minutes, an oncologist really has to have a good understanding that here are the alterations, here are the therapies that I can utilize to treat my patient. So in addition to that, it's really important to support your local physicians as well as your local oncologists. And so we've actually set up email groups that are monitored 24 hours a day, 7 days a week for any questions that come back, or any questions on what do the results mean, test interpretation questions, or, hey, I have a question about what test I need to utilize. And so can you help me with that? So again, it comes back to the education and engagement, where the pathology division, as well as the molecular team, as well as the AP team, we have to also continue to guide appropriate test utilization. And so some of the things that we've done is that we've created biomarker testing guides and protocols, and these are emailed out to our physicians, our pathologists, as well as our oncologists, and they are updated on a quarterly basis. As Dr. Vanderlyn pointed out, the NCCN guidelines is being updated very regularly, and so we have to also be on top of all of that and make sure that we're on top of all of the latest publications and get that to our laboratory operations staff, our physicians, as well as our oncology clients. We've also started running molecular tumor board series and interesting case conferences. And so these are live interactive discussions between pathologists, laboratorians, scientific directors, oncologists on the topic of what do the test results mean? How do you utilize the test? And when is the most appropriate time to utilize these tests for patients with advanced lung cancers?